Hello, pharmacology friends. I would like to talk to you today about bipolar disorder type 1 and 2, and mainly our top choice for treatment, which is lithium. One of my very favorite things in pharmacology is looking at drug history. Almost all of them have fascinating histories, especially psychoactive medications. And you might know that a lot of medications that are either prescription now or illegal now were used in a widespread nature. They were available over the counter. They were ingredients in normal things like Coca-Cola had delicious coca syrup in it, in addition to the main ingredient in the coca leaf, which is used to make cocaine. Fun fact, Coca-Cola still stays true to their roots by including coca syrup in their product now. That's why it tastes a little bit different than, other dark sodas that start with like a P or a cola. So they still have that coca in it, but they've removed the active ingredient, fortunately or unfortunately, depending on your view. Another soda that has changed its formulation over time was good old 7-Up. 7-Up was a lithiated soda. So if you think about what we just said about lithium, it's a medication that is a mood stabilizer. If we are drinking it in a soda, we're going to see a lot of mood stabilization. Here's a great print advertisement of this little toddler child, probably in their playpen, and the mother parental figure letting them chug some delicious lithiated soda. Why do, babies look really calm in the 50s? Why did kids listen really well? Not like those kids today. It might be because they were consuming quite a bit of lithium. All right, so as promised, let's focus on lithium, which remains the first line treatment, especially in bipolar type 1. Bipolar 2 has a little bit of a different presentation, so we might see anticonvulsants used more often as a pharmacotherapy that is primary, whereas with bipolar 1, lithium remains the main choice. So if you remember chemistry, who doesn't? You might remember lithium is on the periodic table. Like, that's how small it is. It's this little, light alkali metal, and it looks really similar to sodium. That's important for later. It also looks really similar to iodine, also important for later. When you give a neurotypical individual lithium, there are no psychotropic effects, meaning there's no brain or behavior effects. There can still be general physiologic effects, which is definitely true, but that doesn't mean that they have a psychologic response. It is 60 to 80% effective in treating acute hypomanic and manic episodes, meaning if somebody is hospitalized for mania or hypomania, lithium is most of the time going to resolve that episode. Also going with the history of medications that I just love. In the 20s, it was used as an anticonvulsant. It turns out it wasn't great for that, so it was shelved for a little bit. In the 40s, that's when we started to see this link between diet and cardiovascular disease. So we started to see the rise of popularity in the low salt diet, or, limiting salt to limit blood pressure. Lithium, because it's a salty alkali metal, it worked really well as a salt substitute. So if you didn't want to sprinkle salt on your food, you could sprinkle some lithium on your food so you don't get the hypertensive effects. Turns out that did have some physiologic effects along with it for some individuals, because lithium is also a mood stabilizer. In 1949, it was involved in just a general lab trial. So imagine an animal laboratory with cages all along the wall filled with guinea pigs. And if you've ever been by a guinea pig, they call them pigs for a reason. When you walk by them and they think they're going to be fed, they squeak and they make a ton of noise, and they're really excited about being fed. head. What they found is that when guinea pigs had lithium in their drinking water, they were far calmer. So those people working in the lab thought, hey, if it works for these loud guinea pigs, maybe it'll work in suppressing mood or mania in people. And in 1970, there was quite a bit of a jump there. They had to convince some people, but it was found to be clinically relevant in treating bipolar disorder. Why also it's important that we have other medications like the anticonvulsants on the market is we can pretty much, even though the numbers are, off, let's round them. About a third of patients discontinue lithium for a variety of reasons. The second third, a little over a third, they take, but they do have reoccurrences of mania or depressive episodes. And the last third, a little less than a third, they take lithium on its own and they have no further episodes. So some individuals are fine on lithium on its own. The other greater than a third might need an adjunct medication to enhance the mood stabilization properties of lithium. Okay, so here are what the Escalith or generic lithium tablets look like. So if they're taken as a tablet, that means that it is mainly an oral medication. When taken orally, really rapid and complete absorption. Like most other medications, it's got to make it down the esophagus, into the stomach, and it's absorbed mainly through the small intestine. Because it's this metal, it does have to accumulate in the system, so we won't see immediate magic effects. It has to get to a therapeutic level, which takes about 2 weeks. It does cross the blood-brain barrier, but because it has a charge associated with it, that isn't a great, fast crossing into the neural tissue through that, barrier of blood vessels and astrocytes meant to keep the brain safe. So it's slow and incomplete, but it does get there. It's small enough, but it does have a charge. With regards to lithium, how much smaller can you get in the body? Our body can't make lithium any smaller. So that means the liver is really off the hook for lithium. It doesn't have to metabolize it into smaller byproducts. It can be excreted. That also means you can look for lithium in the urine because it's not changed at all. Other tests for medications are looking for a byproduct of that medication to see if it was taken. So that excretion, when you're looking for lithium or confirming that the dose is correct or that the patient is adherent to their regimen, because it's unchanged by the liver, it is excreted in its unchanged form by the kidneys. So it's excreted through the urine. It is removed. Its half-life is about 18 to 24 hours, and complete removal from the body is about 1 to 2 weeks. So it takes about 2 weeks to build up, takes about 2 weeks to fully leave the system. Really important pharmacologic note. There is something called a therapeutic index. And what a therapeutic index is, let me just erase that for a second. If we draw a graph of doses and how well they work, so this is called a dose response curve with dose on the bottom and response on the y-axis. What we see is that as dose goes up, we see a greater response to that medication. This would be our dose response curve for our good effects of the drug, what we're giving it for. So the higher the dose, the better good outcome a lot of the time. There's also dose response curves that go along with the negative effects of the medication. So meaning if we were measuring on this curve, weight gain or GI disturbances, we would see that as the dose goes up, we see a greater effect of those negative side effects. So when medications are dosed, essentially what you want to do is find a space, find a dose that's appropriate, between those two curves. So you want to choose a dose that's high enough to have the good therapeutic effect, but not so high that we're going to cause negative side effects. That space between the two curves, that's called the therapeutic window or therapeutic index. Some medications have really wide therapeutic windows, meaning you can take a whole bunch of that drug before you get negative side effects. Lithium is not one of those. The space between those two curves is very narrow, meaning that you have a little window of doses to choose from. If you give a little bit too much, you're going to have toxicity, and toxicity is medical talk for side effects. So very low therapeutic index between 0.5 and 0.7 millicues per liter of blood is around a dose where you'll see nice therapeutic effects. However, once you get to about 2 millicues per liter of the medication, that's when we're seeing toxicities. That's when we're seeing negative side effects. But you've got this tiny little window, right? So you want to make sure you choose correctly, or you choose the perfect one, which means you might have to titrate. You might have to change those doses. Lower doses, they have a less likely chance of causing recurrent manic symptoms. However, higher doses are more associated with adverse effects and what we call non-compliance or non-adherence to therapy. In order for pharmacotherapy to work, one of the most important things we can't forget is that people have to take it. If taking the drug leads to really adverse side effects, then people won't take it. Why would they? So that was your pharmacokinetics. Pharmacodynamics is how things work with your body. How do they bind to receptors and have an effect? And lithium is an interesting paradox. It's one of these drugs that we figured out works pretty well without even knowing how it works. And today, it's still a complete matter of speculation as to how this drug works to relieve mania. Because remember, in normal populations, it's not psychoactive, not psychotropic. There's no euphoria, sedation, depression. It only seems to work in people with bipolar disorder. So how can this tiny little lithium ion affect multiple transmitter systems? So it seems that there is an effect on neuron responsiveness to synaptic input. Again, like in a migraine or in a seizure, there's too much activity from certain neurons. They get overactivated at a certain point. So basically, we want to quiet them down somehow. And lithium seems to stabilize membranes and specific serotonin receptors. All right, now we're on to the fun part, the proposed mechanism of action. If you are not here for the hardcore pharmacology, maybe this is a good slide to slip on past because we're going to go right to it. Love this stuff. So what you're looking at here, this is a phospholipid bilayer. So that's the plasma membrane of cells. Remember, some things can make it really easily through the cell membrane if it doesn't have a charge and if it's highly lipophilic, meaning it can dissolve through fat. Phospholipids, so these guys right here, those make up 97% of the plasma membrane, and the remaining 3% is cholesterol. So if something is dissolvable in fat, it can go right through that membrane, no big deal. Other things, they need to come in some other way. And one of the ways they can come through is a channel. And in order to get a channel to open or some sort of cellular activity to work, we have receptors. And receptors are things that receive chemicals, receive drugs, neurotransmitters. They are able to bind those things. This is what we call a G protein coupled receptor. GPCR. So it looks like a Loch Ness monster here. It is drawn with its 7 loops traversing the membrane. Remember, trans means across. So there are 7 transmembranous loops that allow for binding. From above, these things are folded into a loop, so things can go through, the center of them if necessary, but we tend to draw them in a schematic like this. All right, so G-coupled protein receptors are called that. So we learned why they're called 7-transmembrane receptors. That's the way they are formulated. That's the way they look. The G protein is what drives its more common name, G-coupled or G-protein coupled receptors. This big old blue thing here, that's a G protein. G proteins have 3 subunits to them, an alpha, a beta, and a gamma. And just like your A student is the one that does the most work, that is what our A alpha subunit functions as here. So if something and when something binds to our G-coupled protein receptor, let's say like something binds here, that would create a change in shape of the receptor. And when there is that shape change, we call that a conformational change. When the conformational change occurs, that causes the G protein to dissociate. And not the whole thing. The one that pops off is the alpha subunit. And the alpha subunit pops off and deals with the next messenger in line. You might also call these second messenger systems because instead of something binding and something opening, we have something binding and then multiple steps and then something happening. So the alpha subunit works on the next enzyme in line called the PLA or phospholipase enzyme. And what phospholipase does is split this big old precursor, PIP2, into 2 components. One of them is called DAG, and the other one is IP3. So when PIP2 breaks into these 2 parts, the first subunit, DAG, doesn't go do really anything functional. It's what we call a membrane-bound protein. So DAG just sits in the membrane. And it's like, dag, I wish I could leave the membrane, but it can't because it's membrane bound. The active part of the second messenger cascade is our IP3. When IP3 goes through its active phase, because it's activated by a protein kinase, IP3 drives the release of intracellular calcium from the sarcoplasmic reticulum inside of the cell. You still with me? This is cell biology. You love it. I love it. So calcium is stored inside of the cell. Calcium's a positive ion. IP3 lets out this positive ion. So we've got calcium here now outside of the SR, just inside of the cell, driving up the charge of the cell so that that cell can fire and go and do whatever its job is. So if this is an overactive cell in bipolar disorder and when it fires, we get symptoms of mania, this G protein activating PIP pathways into IP3 will drive calcium release, will drive up the charge of that cell, and will get an action potential. It is postulated that lithium works within this pathway whereby IP3 is going to go conform back into PIP2 with all of its parts ready to be activated again. There is a certain step here, the creation of inositol. Inositol is really important in the IPs going back to the PIP formation. So it's postulated that lithium depletes inositol. If it depletes inositol, what it does is arrest that conformation process. So things cannot go back together to become PIP2. So if PIP2 doesn't exist, we never have activation of this cell. So essentially, lithium is going to mess everything up so that we don't get an overexcitation of that cell. This is our theory. It seems to be probably the case, but as we know, we can't make anything in science a fact until we know it for sure. All right, so just our toxicities of lithium, because this is a metal, metals do accumulate in the central nervous system, which means they can slow things down. That's what we see here, just mild side effects. So maybe a postural fine tremor or, mood dysphoria, problems with memory, slower reaction time, irritability, my favorite behavioral term. It means the narrowing or the lessening of personal space. What a great definition. Usually you've got about 3 feet around you of personal space. This makes it really wide. Maybe it's 5 feet, 10 feet, or 2 miles. That's what happens when you're irritable. The other things, and one of the main reasons people stop therapy is because of the weight gain. About 30% of people develop a BMI that's categorized as obese. Also, GI issues, nausea, vomiting, diarrhea, abdominal pain, and as I mentioned, these CNS problems that as the dose goes up, they start to progress to more moderate in their severity. So slow movement, feeling dizzy, difficulty focusing your eyes, slurring of speech, tiredness, muscle weakness, blurred vision, increased deep tendon reflexes, peripheral nerve pain. So these are things that might want you or might cause you to back up on a dose or maybe switch to something else. Another long-term thing, so I mentioned that metals do accumulate, so that is something that until the drug is removed from the system, we will see, memory and cognition issues with long-term use. Another thing you will see, though, is thyroid enlargement. Why does that happen? That happens because in order to make thyroid hormone, your thyroid needs iodine. And iodine is incorporated into the precursor for thyroid hormone. So in order to make T3 and T4, you need iodine. Guess what? Lithium and iodine look pretty darn similar to those cells in your thyroid. So that means the thyroid will take up that lithium and use it to do things that it's not supposed to do. And the more active an endocrine gland is, the bigger it gets. So you'll start to see thyroid enlargement. You'll also see an increase in urine output with long-term use. So checking kidney functionality is important because you can get literal overuse of the kidneys. Remember, we start to see toxicities at about 2.0 millicues per liter. The really dangerous dose is once you get up to 2.5. That's when you see muscle rigidity, coma, kidney failure, abnormal heart rhythms or lack of a normal rhythm, and that can progress to death. So remember that narrow therapeutic window. You want enough of the medication that it's working, but not so much that you're getting these negative effects. And then the longer you're on a medication, the more likely those effects are to occur and then just continue occurring. One note I do want to mention as a side effect as well is that lithium is not indicated during pregnancy. And this is really difficult because just like seizures, mania, and other mood disturbances in somebody who already has them, they tend to be worse during pregnancy. And lithium is one of the medications that's considered generally teratogenic. This is a table just looking at various medications that interrupt embryonic or fetal development, and this is looking at cardiac defects. And we tend to think of things like, alcohol, amphetamines, things that are not necessarily good for you during pregnancy, that everybody knows aren't good for you. But then there's the medications like lithium that can cause heart defects, like retinol, which is used for acne treatment and aging regimens. That causes just as many cardiac defects. So remember, the first trimester of pregnancy is when everything is forming. After the first trimester, things just get bigger. So ideally, if somebody needs to be on lithium, if it can be avoided during the first trimester when everything is forming, that would be the best case scenario. As mentioned before, all right, we're trying to get rid of this term noncompliance and use non-adherence so that it doesn't sound so terrible. Like, you're non-compliant. It's non-adherence to the pharmacologic regimen. And about 1 out of 2 patients against medical advice will stop taking their lithium. The main reasons that are cited are the intolerance to the side effects, like the cognitive issues, the memory and energy issues, the weight gain, and then missing the euphoric manic episodes. If you do say that on the bipolar subreddit, you will get banned. So even though that is one of the main things people report. However, even though there are side effects that are not desirable, we have really important outcomes when we have an appropriately treated patient with a great, on the nose diagnosis. Lithium reduces suicidal behavior by about 80%. When somebody stops lithium, the rates of completed, so not attempted, but completed suicides increases 13-fold. So that's huge. So we want to make the medication as palatable as can be so that individuals continue taking it. And once lithium treatment is started, it may be necessary for the lifespan of that patient. All right, again, some people are intolerant or maybe they don't respond to lithium only. When somebody is on lithium only, again, about 60 to 70% of patients who take it, so not that they're non-adhering, if you remember our statistics from before, but looking at everybody who takes it, about 60%, like we saw before, they can be controlled with lithium only. Those who have more than 4 manic episodes, at least in a year, or it depends who is making the criteria, but a rapid cycler is somebody who goes from manic to depressive through these episodes more frequently than others. They're more difficult to treat. So that is why there are alternative medications and the anticonvulsants, which are FDA approved either as just single or monotherapy or adjunct agents to lithium. All right, so just a couple anticonvulsants that are on the market to treat bipolar mania specifically. Carbamazepine, this seems to be as effective at treating mania as lithium. It works with rapid cyclers, which is good because they are difficult to treat. Then second, we have the most commonly used anti-mania drug, or at least the anti-seizure medication used, which is valproic acid, sold as Depakote, Depakine. And this is a GABA drug. If you remember your neuro, GABA is our main inhibitory neurotransmitter. So valproic acid, it kind of inhibits neurons, it does inhibit neurons. It hyperpolarizes them so that they're less likely to have an action potential and do things. And if neurons are quiet, they're less likely to fire and then cause mania. Gabapentin is another medication that is used off-label a lot of the time, and it's something that looks just like GABA, so that is used, again, to quiet down cells. Lamotrigine is a medication that is becoming more popular. It's also in the past couple of years been used also as an adjunct to SSRIs, or sometimes people switch their patients from SSRI to lamotrigine, which is sold as Lamictal. And this, instead of enhancing GABA, which is our main inhibitory neurotransmitter. So if we picture this as like a scale of inhibition and excitation, glutamate is our main excitatory neurotransmitter. So that turns everything on, where GABA turns everything off. So the medications prior, they promote GABA to turn off neurons in the most simplistic way. Whereas glutamate, if we inhibit that, well, then we are stopping things from being turned on. Topiramate and tiagabine are two adjunct therapies that can be added to either the anticonvulsants or to lithium. They seem to offset the weight gain. Unfortunately, we still do see quite a bit of weight gain, especially with valproic acid. So adding those can offset the weight gain a little bit. These are other medications. Not only are they used for anticonvulsant, but they're also used in migraine therapy. Again, that same pathogenesis and signaling we see with migraine, seizure, and mania. So there's a lot of overlap with those different disorders. All right, so that is the basis of pharmacologic treatment of bipolar disorder. I hope you learned something. I hope you enjoyed learning a little bit of history, and it was a pleasure. So thank you, everybody. Stay smart.